Dr. Osama Haji. He's a rheumatology senior consultant, Muwasat Hospital, Dammam, and he will talk about herpes zoster vaccination in immune-compromised rheumatic patients. So please, Dr. Osama.
Yes, okay. Everything will be clear if you take a short message. All patients with immune compromised should be vaccinated, and we should take care. If we think where we are in daily clinical practice, check your agenda for SSR. You will find the last day, the last session, the last lecture will be about vaccination. After this presentation, I am inviting all of you, to fix vaccination in a proper way. Why vaccination is important daily clinical practice? Because we are dealing with immune-compromised patients. Not all patients will be the same. Of course, if your patient is axial spondyloarthritis, receiving only non-steroidal anti-inflammatory is not equal to SLE, as stated with Dr. Manal in an elegant way. No SLE without steroid, no SLE without immunosuppression, no SLE without B-cell depletion therapy. All this invite us to concentrate about immune-mediated disease. Yes, this meeting is sponsored by GSK. We'll cover all these points in a very simple way. But this is a main message. This is a main message. Yes, I'm receiving Nouronium for this meeting, but there's no competition because RVZ, recombinant zoster vaccine, has no competition. It is the only one recombinant. The other one is not available in Saudi Arabia. And it's covered by MOH. So what is the barrier of not vaccinating our patient in daily clinical practice? We have no option because most of our patient is immune compromised. Why we should do like this? Because we, in daily clinical practice, all the recommendation now put vaccination in a very important initial step. If your patient diagnosed as a SLE early, without life-threatening condition, starting hydroxychloroquine, you have option to vaccinate the patient early. If your patient life-threatening, receiving a high-dose steroid, you have to decide what is the proper time for vaccination with low disease activity, with low dose of immune compromise, the same as we have in COVID-19. But that's why KDIGO, what say, kidney disease improving global outcome, for the first time stated by name. The vaccine must be implemented for each patient with SLE. It's not KDIGO only, it is individualized consideration for recombinant zoster vaccine. EULAR, published in 2024, stated in a very clear, prevention of infection for each patient with SLE, it is an important issue, and we have to implement for this. This is a very important to implement in daily clinical practice. Why we are thinking of shingles? I can give $1,000 لو حد قال لي باللغة العربية زوستر اللي هو العنجز باللغة العربية اسمه حماق باللغة العربية is zoster, right? But حماقة is not to vaccinate the patient in daily clinical practice, right? Why this? Because every one of us has a primary vaccination of varicella, chicken pox. And with time, the patient is developing reactivation of his herpes zoster. And it's very painful, and we have no option in treatment of this patient. What does it mean? Above 99.5, it is like election in the Middle East. 100% of the patient has a zoster vaccine. Zoster infection, and 1 out of 3, it means if your patient attending, they have a zoster and he has reactivation of this. It's not only like this. It is a very important curve that with time there is a building cellular immune response. Remember this name, cellular immune response. And cellular immune response is decreasing with time. This is an immunocompromised patient, immunosenescence. Immunosenescence, what does it mean? That the cellular immunity is not like before. With time, it is decreasing. Okay. But in immune compromise, it comes early. So your patient is liable to have zoster vaccine, herpes zoster, your patient liable to have a complication, your patient liable to reactivation and recurrence. Why this? Because we have two groups. Your patient, either older age group, 65 and more, or 50 even and more, or your patient immune compromised from the age of 18 to the age of 50. Which your patient like this, and you have to fix what is the proper and excellent time to vaccinate your patient to gain the maximum immune response. And this is a lesion, if you are not treating, it can become aggressive, it can become complicated. Even so, it can become the worst case scenario. The worst case scenario, the patient may develop zoster pneumonitis, zoster meningoencephalitis, and the patient can develop zoster hepatitis, which would be life and critical for our patient if we are not vaccinating in the proper way. Not only like this, the patient is liable for recurrence again. This is for SLE. For rheumatoid, yes. No rheumatoid without the steroid. Even if you like to reduce the dose, but still the dose will be higher. So zoster, it can be exacerbated by prednisolone. Up to what? No, down to what? Down to 10 milligrams, the patient will be liable to reactivation. That's why we have to take care about all patients receiving steroid. Not only like this, all biological therapy giving to the patient who's RA, making zoster reactivation is a very important method, especially JAK inhibitor with variability. So 40% of the patient, 40% of the patient receiving biologic have zoster, they have severe, and we have to take care about this. Not only like this, the patient with HIV, it is part of the story because cellular immune response is decreased in patients with HIV. Again, the patient with a transplant, they have a problem in daily clinical practice. The patient with all manifestation, the patient with all manifestation, especially the bone marrow transplant, because they are severely immune compromised. We have to take care about this patient. Why? Because this is not for the patient. The family history of zoster give a red signal that we have to take care about this patient. Why? Because if your patient is immune compromised and one of the family is affected by herpes zoster, your patient is liable for reactivation. That's why we should not take care about the patient only. The whole family member should be vaccinated if they are in contact with the patient with this. Very important, more than age of 50 or less, and how to treat. It's not the scope of this, but it is difficult to treat. Why? Never ever in daily clinical practice to treat herpes zoster in a proper way, because the patient is coming after the window of opportunity. Window of opportunity, it is with pain, with eruption. If the skin eruption is coming, no hope to treat this patient in a proper way. And you have to give only treatment or analgesic effect. But the most important is vaccination. What about the American College of Rheumatology recommendation published in 2023 for this? It is a clear way. Strongly recommended with influenza vaccine. This is the only tool that it is recommended to be given to every patient with immune compromised condition. What about the medication? Methotrexate, I prefer to hold methotrexate for 2 weeks if possible. But ACR recommends that you can continue methotrexate. What is the most important challenge? The most important challenge that the patient receiving B-cell depletion therapy. The same like COVID-19, you have to make a plan. If your patient receiving B-cell depletion therapy, you have to make arrangement in the 5th or the 6th months after infusion. You can vaccinate your patient, and you can delay the next dose of B-cell depletion therapy to give the best option for vaccination of the patient in daily clinical practice. Other than methotrexate, you can continue. Yes, even if you are giving methotrexate with Zoster vaccine, it means that the immune response will not be 100, but it will be less. That's why we have to continue. The most critical point, especially with the patient prednisolone, Dr. Ramiz, أنا بفكرك فضل 5 دقايق. أنا بفكرك. أنا متعاون أهو جدا أهو. Yeah. Steroid is a very important in daily clinical practice. But the issue, if your patient receiving more than 20 milligrams per day, you have to take care. You have to postpone vaccination until you can taper or down steroid dose till the patient will give the best option how to be vaccinated in daily clinical practice. Yes, we have very specific action with recombinant zoster vaccine. It is specific by Ig, glycoprotein E, and recombinant that you can make more stimulation of the immune system. This is a very important message that you can protect your patient from reactivation, you can protect your patient from complication, and the issue is that not answer for how long. It is the matter of that we can take knowledge from our oncology team. Why? Because we have no specific clinical trial in daily clinical practice with SLE, with rheumatoid only. It is post hoc analysis. What about the most hard one? The most hard one is, yes, the most hard one is immune deficiency, autologous hematopoietic stem cell transplantation, hematological malignancy, renal transplant, solid tumor. This is the worst case scenario, immune compromised patient, and still the figure is high. In general population, the figure is more than 90%. It decreases in immune-compromised patient to catch the figure of 70, between 70 and 80 in daily clinical practice. How we can treat that patient? There will be something like local side effects. It can be expected for any immunization, injection site reaction. It can be very mild systemic manifestation like fever, shivering, headache, myalgia. It can be expected. And the most important, this is the most important slide. Remember the first one, and this is the second one. Why second one? Because we should vaccinate the patient for general population, the first dose, then the second dose after 2 to 6 months. Why 2 to 6 months? This is a very important dose, and you have to repeat it to gain the maximum benefit. If your patient is giving only single dose, the efficacy will be less. If your patient receiving 2 doses, it is 4 times more vaccination. That's why, I will come here, right? I'm the speaker. Be with me, please. Yes. So the second dose is a very important one, and the second dose for immune-compromised patient is between 1 and 2 months. You can decide, but all the patient must receive 2 doses of the vaccination. If you are less, it will be much. It's recommended for everyone. MOH recommended the patient must receive Saudi Arabia Ministry of Health for general population, American College of Rheumatology, EULAR, all are recommending. But the issue is, what is the best time to immunize your patient? So I will make it simple like this. If your patient is not a life-threatening condition, giving a hydroxychloroquine to the patient with SLE, and you are still starting, this is the best time to vaccinate your patient. And don't miss this window of opportunity. The same like if your patient is starting bilacoline, even methotrexate, as a starting methotrexate will not handle the side effect of medication. That's why we have to utilize the time. If your patient has disease activity, bring it down, bring steroid down to vaccinate your patient in a proper way. This is the option that we have. We have to vaccinate the general population. We have to vaccinate immune-compromised patient between the age of 18 to 50 to give the patient the best option protection against complication, against reactivation of herpes zoster. By this, thank you for your time and attention. Dr. Ramiz.
Thank you very much. We will have a couple of minutes for questions, so may I call the speakers. We are already late and we are behind the schedule, so we will allow 2 questions. Quick one, please.
I'm blaming myself. I'm not vaccinating my patient in daily clinical practice. I'm wrong, right? But the issue, who is the team leader? Do you think in National Guard, His primary care physician, rheumatology, or family medicine. Which one must take the lead to vaccinate the patient?
I think according to the population. Our patient is our responsibility, and for the general population is for family medicine. But I think we are the one who should recommend the vaccine for our patient. If it's not from us, it will not be.
I believe we should vaccinate our patient in a proper way. Why? Because if a primary or family physician will vaccinate, they don't know about the side effect of medication, they don't know about disease activity. That's why at least we have to synchronize between both of them to vaccinate our patient in daily clinical practice.
Okay, any more question? Yes, doctor.
Yes.
Can we get the microphone for him?
So my microphone is with me, Doctor, here.
Oh, sorry.
So my question is for the Prof. Osama. Yes, Osama.
Where are you? Here. You don't
Yes,
back-
please. You know, my question is regarding a patient who who are already infected
Yes.
with the shingle. Do you vaccinate?
No.
Number two, if patient with recurrent zoster infection.
Yes.
So we have, sometimes we are facing this type of patient who they develop infection, and they comes again with reinfection. So, I have patient 3 times zoster infection. So what's your advice?
Yes. Okay. I will make it in a very simple way. If the patient has acute zoster, don't vaccinate this patient at proper time until it is completely resolved and pass at least few weeks, and then at that time you can vaccinate your patient again. If the patient receiving before 1 dose, you can give the second dose, or you start vaccination by 2 doses after resolution of herpes zoster completely. This is the first point. If your patient has recurrence, I will go back to live vaccine. Live vaccine, they advise it, make it simple for myself and for my colleagues that one. What does it mean, one? For biological agents, you have to drop single dose. For JAK, you have to drop 1 week. For any other biological therapy, stop for 1 month, methotrexate 1 month. And then after revaccination, you can give drop again 1 month. So this patient, first of all, we have to control disease activity. This is the most important one. We have to adjust the medication because the patient has recurrence. And the third, we have to vaccinate our patient in 2 doses, separate one for 1 to 2 months to give the patient the best option to be vaccinated against zoster and the complication. It is not a matter of skin. It is not a matter of pain, post-herpetic neuralgia. It is a matter that the patient may develop something else that it can be life-threatening condition, Dr. Bat. Okay? شكرا جزيلا دكتور.